Good morning, everyone. It's Jason Anderson, National Sales Manager for Medmont International here, welcoming you to another webinar. This webinar we're hosting today is going to help you understand what eye shape tells us about contact lenses. Again, we have the esteemed presenter, Randall Kajima. Welcome, Randy.
Hey, thanks, Jason. Thanks for setting up these sessions. It's nice to be with friends and colleagues from Australia and New Zealand, even though we can't be closer at this time. I hope everybody's enjoying a bit of easing of restrictions down there. I've been following the news, and it sounds like you guys are going in the direction of being able to go to the pub, which I think all of us want to do. This talk will be about how we can look at topography and have it be a guide for us related to contact lens fits. You know, what does the topographer tell us before we begin that could assist along the way with lenses, essentially, is what we'd like to talk about today. Now, topography is really a tool that can be used with every type of specialty contact lens and conventional contact lens. You know, certainly we use it much more in the irregular cornea than we might in the totally normal eye, but let's go through all the various things that we can do, or as many as we can today, and try to have an understanding. Now, keratometry has always been our tool that we use to appreciate eye shape. Of course, it helps us to understand eye radius. It helps us to understand the corneal astigmatism as it might relate to the refractive astigmatism. So when we take a K reading or get our sim K from the topographer, that of course is taking a reading at 3 millimeters diameter, or approximately 3 millimeters, 1.5 mils from the center. But it doesn't tell us a whole lot about what's happening at the apex of the eye, and it doesn't tell us anything about what's going on in the peripheral cornea. So slightly limiting in scope, where when we have topography, we could look at this patient and say, this corneal shape is really ideal to bend light. We would say that the powers distributed within the pupil are pretty uniform across almost 100% of the pupil. So one can imagine this patient's best corrected VA should be exceptionally high based on purely corneal shape. This eye should be ideal for bending light. When we look at this patient, we might say, is this similarly somebody that should correct to a very high level of visual acuity? And I think we could argue that yes, this patient would. We have 1 diopter of width the rule astigmatism, or about 0.2 millimeters of corneal astigmatism, for those of you think in millimeters. But what's noticeable is the flat meridian and the steep meridian are 90 degrees apart, so our spherocylinder refraction should work quite well. We also notice that the inferior hemisphere is a mirror of the superior, nasal a mirror of the temporal. You know, the power distribution within the pupil across those two meridians is really ideal. It's really symmetric. So providing this patient with good acuity, with glasses, with soft lenses, with rigid lenses, with anything really is a non-factor, should be quite straightforward. But then we have this patient, and of course this one clearly is a patient that would be challenging to provide quality of vision. So when we think about contact lenses, now are we narrowing our choices down to really only rigid lens optics, where you look at the distribution of power within the pupil. Here at the peak of the cone, we're at 63.5 diopters, and within the central pupil, or pardon me, within the pupil, we're at approximately 36 diopters. So that's what, about a 27 diopter distribution of power between this point here and this point here. You know, there's specialty soft lenses to manage keratoconic patients, but can it manage that kind of power distribution within the pupil? I'd be suspect that there'd be any hope of that happening, that really this is a patient best served with rigid lens optics. So the K-readings, of course, are valuable to us. It gives us the perspective of the radius of the eye, how steep or how flat it is, but really we're not understanding the big picture. And here's 3 patients with almost the same flat K, but of course, very different requirements for visual options. You know, would you be able to fit all 3 of these patients with glasses? Would you be able to fit all of these 3 patients with soft lenses? You know, clearly we're going to have to tailor our lenses for specific eye shapes. Now, apical radius is a really important value, and that's one that an Aussie named John Mountford taught me all about and given me a real appreciation of. And today I look at apical radius much more than I look at K readings because it tells us the radius of the eye at the apex. So if we're trying to understand corneal curvature, shouldn't we begin at the center rather than part way toward the periphery or away from center? And in this case, what we're trying to measure is the curvature of the cornea right at the visual axis or at the center of the topography. In this case, this patient has a 45¼ diopter apical radius, or about 7.45 millimeters. Now, why is this value so important? And of course, speaking to Aussies and Kiwis, I know you're all so familiar with using apical radius related to a subtraction map in orthokeratology, comparing before ortho K to after ortho K and measuring the difference on the visual axis. This eliminates our need to have to do a refraction post-ortho K, because when we compare pre and post topographies on the axial, click our cursor in the middle, it'll tell us the radius difference between those 2 visits. How much did the ortho K treatment flatten the cornea out, and therefore how much myopic reduction did we create? So for this patient, a 2.5 diopter myopic reduction, we should have exactly a 2.5 diopter change in refraction. And in fact, after a night of wear, I think the topography is a little more accurate than the refraction. The patients tend to eat up a lot of minus in the initial days of orthokeratology. Their eye hasn't completely smoothed out. The epithelium hasn't generally responded in a uniform manner. It takes 7 to 10 days for the eye to achieve full effect. So it's very common when we refract patients post ortho K in the first few days that they will take more minus than what they may actually need. And often visual acuity would suggest the patient is doing fairly well, but again, they might eat up or soak up the minus. So using the apical radius makes a lot of sense because it takes a lot of that noise out of the way, that the imperfections in our treatment that may be toward the outer side of the pupil, or pardon me, toward the peripheries of what we can measure within the pupil. And that might be creating aberrations that the patient doesn't know how to interpret, and that may be picked up as minus. So using the apical radius on the axial subtraction is a really valuable tool. Now, you can't really use apical radius on a tangential map. It tends not to be as accurate as it is on the axial map. They both should be relatively similar, but the values within the pupil on the axial map will more likely be more accurate than on the tangential. Now, what about for soft lenses? Does apical radius matter in soft lenses? And here's a patient that was fit with silicone hydrogel lenses, and after a week of wear, we suddenly had this kind of missing over-refraction that really wasn't predictive. It was a simple, normal cornea. We shouldn't be missing almost a diopter of power. And when we did a subtraction and compared the naked cornea to the post-removal of the soft lens cornea, we had almost a diopter of steepening at the apex. So our silicone hydrogel lens was creating some steepening in the central cornea. And that's picked up again by this subtractive map and being able to understand how much power we're altering on the in the corneal power by using that apical radii. It's a very helpful little value to use. How about a patient with GP lenses? And you can tell in this topography why this patient had such severe spectacle blur. This is really a normal cornea, but when you look at this topography, post removal of the GP, you don't see a very normal eye shape. We certainly don't see the figure 8 astigmatism that we're accustomed to observing. We can see this arcuate flat spot running right through the pupil, and then this very kind of symmetric smile down here that isn't typical at all of normal eye shape. So if we allow that eye a few days to normalize, and here you can see the more regular with the rule astigmatism beginning to form as that cornea takes on its normal shape. And we're seeing what's happening within the pupil, how much the cornea is steepening down here over time as we allow that cornea to take on its normal shape. Because the GP isn't creating the molding, basically it was a really flat fitting lens that really shouldn't be deemed acceptable for that eye. And so this patient was clearly somebody who needed a refit. But you can tell from the subtraction how much change is going on over time between just these two visits, 4 days apart. There's a massive amount of shift. Now let's think about this another way. What if this were a 16-year-old kid that appeared to have the signs of possible keratoconus? And should we be sending this patient off for cross-linking? Or is the patient's topography just a droopy apex, a steep inferior cornea? Well, doing a subtraction and comparing this visit to 6 months from now, if there's no change, if the topography comes up all green, that's telling you there's no shift in power over time. So therefore, we are unlikely to need to send this patient off for cross-linking. Certainly, it's indication that topographically there aren't any changes. Of course, we should be monitoring the slit lamp signs, the visual signs as well, but topographically, if you're not seeing any colors popping up other than green, that's saying that between the visits, the cornea has not changed. So the axial map is that tool, at least that I use routinely. I look at every topography in axial interpretation first. Sometimes I'll switch to tangential, sometimes I'll switch to elevation, but the first step for me at least is using axial. Some practitioners prefer only tangential as their starting point, and that's fine. It's however you get used to it. For me, I'm always interested in how does the corneal shape contribute to the patient's quality of vision, and how does that guide our decisions? So axial is definitely the tool for vision. Now let's talk about some other things that the topographer can do related to us fitting contact lenses. And one of those super simple things is visible iris diameter. For all of these patients, if we would have done a better job measuring the VID, we might have had a better contact lens outcome. We might have had a higher first fit success, but all of these lenses were poorly chosen because we weren't paying attention to the VID. So one of the considerations is, at least in this study, and that should be fairly similar in Australia and New Zealand, where it was done here in North America with mostly Caucasian eyes. But what you find is the average visible iris diameter is about 11.8, at least in this study in North America. We know that in Asia it comes up slightly smaller, maybe around 11.6 is the average visible iris diameter in East Asia, but for Western nations, let's assume that the average is around 11.8. Now, what about all these patients that are at the extremes? Well, approximately 1 in 4 patients that we might fit in contact lenses has a visible iris diameter that's very much on the small or large size and may not be best served in conventional diameters of, let's say, soft lenses, the big box retail brands. So as an example, would you put a 14 millimeter diameter on a 10 millimeter eye? Would that be a lens a little on the large side for that eye? Or similarly, would you take that same 14 millimeter diameter lens and put it on the 13 millimeter eye? Thinking in terms of scleral lenses, would we put a 10 millimeter VID in a 16.5 diameter? And would a 16.5 diameter be big enough for a 13 millimeter eye? You know, generally the rule of thumb that we operate by is a soft lens should be VID plus 2.5 millimeters, or an overlap of 1.25 millimeters on all the way around the contact lens. For a scleral, we want VID plus 3.5 millimeters. So that gives you some rule of thumb that you may follow related to visible iris diameter. And another consideration is when we're dealing with the small cornea, we know that the likelihood of the depth of the eye being much more shallow is obviously much higher. A smaller or shorter diameter would have a smaller cross-section of the curve, so we should have less sagittal depth. In a small eye, we're more likely to need a flatter fitting lens to cornea relationship. Whereas in the larger VID, we would expect with that longer chord of bearing that we should have greater sagittal depth. We're much more likely to need a steeper or deeper contact lens, whatever type of lens we're talking about, be it corneal GP, a soft, a scleral, any of the above. Now, of course, that's not always true. You can have a small diameter eye that's ultra high in depth, and you can have a large cornea that's very low in sagittal depth. It does go hand in hand with the radius of the cornea and the rate of flattening of the eye, but you can generally use that as a very good rule of thumb. Small diameter, you're likely to need less sagittal depth. Large diameter, more sagittal depth. Now, for pupil size, this also is a measurement that the instrument, the topographer, will give us that I don't know if we're probably guilty of not paying enough attention to it, at least at our school. I don't know if we actually look at it and VID as much as we maybe should. And it, of course, is a very valuable measurement related to multifocal lenses. It's a valuable measurement related to myopia control contact lenses today. You know, if we have a exceptionally small pupil and we're trying to deliver multifocality to a presbyope, we have to make sure that that power that we want to provide is within the pupil margins. And if, for instance, we have a multifocal lens where the most plus kicks in at 4 millimeters and we have a 3 millimeter pupil, well, then we probably gonna have a problem. And similarly, if we have a humongous pupil, will that introduce too much aberration and there'll be too much power spread provided, and that'll ramp up the aberrations, and whatever multifocality we're providing might be neutralized by the fact that we've just increased the aberrations for the patient so much. So pupil size, of course, is really valuable related to any type of multifocal optics that we're using, and certainly for single vision optics when we have these really large pupils, and if our contact lens isn't really well centered or doesn't have a large enough optic zone, then that's going to be a concern. Hey, so speaking of pupil, let's talk for just a second about this area on the graph. You'll notice that what Medmont does is it gives you an outline of the action within the pupil. So across this white axis line here, you see the power distribution from the top of the pupil here to the bottom of the pupil right here. And that gives us an appreciation that this eye goes from approximately 40 diopters to somewhere in the neighborhood of 58 diopters roughly. There's a big spread in power between the most plus and the most minus within this eye. So clearly, this is a valuable understanding related to any type of contact lens, and specifically related to what we do with orthokeratology. So as an example, here we might take this case and we would say, is this a good bullseye? Have we distributed the myopic shift within the pupil really well? Is this a well-centered bullseye? And really, it looks like it is. The most effect is here at 0.0 on the visual axis. It's looking really good. Now, is this a good myopia controlling outcome? And you might ask yourself, yes, I've done a good job of creating a bullseye and centering the hydraulic forces, creating the epithelial shift over the pupil. That's great, but have I introduced enough aberration for this eye for this to be deemed a ideal myopia controlling beginning? And what we might look at is the action within the pupil, and let's focus in on what is the effect on the visual axis. That's minus 3.64 diopters. And at the pupil border, we're basically at 0 effect. So going from center, 3.64, there's a drop of approximately 3.62 diopters. So basically, we have a 362 add power. And if we listen to the experts like Earl Smith at the University of Houston, he would suggest for myopia control, push the maximum plus power that's possible. Push as much as the patient can manage before the aberrations become a concern, before the patient starts losing quality of acuity. And that's the way to slow down eye growth. So push the maximum plus. So this is a really important understanding for us, is this area within the pupil that Medmont defines to help us appreciate, have we done a good job of creating an ideal myopia controlling outcome, not just a good bullseye. Related to soft multifocal lenses, again, the same story is true. Let's focus in on this area within the pupil to have a better understanding of if we've done a good job. And you might notice the power spread across this white line within the black pupil, 0.0 right here in the center. That's the visual axis. So here's the power that the visual axis is receiving, and you notice the peak of the plus. This is a center near multifocal lens, and the most minus kind of asymmetrically distributed. This plus right here should be over the visual axis, and this minus should be distributed around the pupil 360 degrees to provide simultaneous vision. So what you have here is the cornea without a contact lens. This is topography over top of the lens, and here we see the powers distributed in relationship to the visual axis, which is the center, and the pupil. So for this patient, if aberrations are a problem and we're not really picking up more multifocality, I understand what might be at work, that we have the optics of the lens, the center of the lens axis and the visual axis are around a millimeter, maybe 0.8 millimeters separated. So we're not really centering this contact lens as we should. Related to scleral lenses, it's not uncommon that we have some odd over-refractions, and we may have to pick up cylinder and add it to the front of our scleral lenses. The study that we did at Pacific U showed that about 15% of our scleral patients require front toric optics. So a pretty big percentage of our scleral patients may need a lens that sits on axis, that can't rotate, so we can provide that spherocylinder refraction on the front. that's a lot higher than we would see in corneal GPs, and this isn't really clearly understood. Why is it that the scleral patient more often needs some kind of toric optic where the same patient in a corneal GP wouldn't? But it is what it is, and we haven't figured out the answer to why we need these front torics. So in a scleral, what do we do when it comes up in these 15% of cases? Well, one thing we have to understand is the contact lens flexing? Is that lens bending on eye, and that's inducing the cylinder? And so topography over top of your contact lens is a valuable piece. And here we see by the K readings that the cornea is basically, or the front surface of our scleral lens on eye is basically spherical. There's only 0.1 of a diopter of corneal astigmatism, or of lens astigmatism. We look at the topography itself, and it's basically all blue. It's one color, telling you the eye is relatively spherical. I keep saying the eye, I mean the lens itself. So we're mapping over top of our scleral on eye, and it's coming up as a spherical surface, meaning the lens isn't bending, it's not flexing on eye. So this over-refraction of plano -150 axis 90 must be internal, and it needs to be corrected with a front toric scleral lens. We can see that the lens is decentered radically, and this is pretty typical. You know, here's a left eye topography. Most of our scleral lenses position temporal and inferior. So if we want to understand the position of our lenses and the optics in relationship to that, do topography over top of your lens, and it should be fairly obvious where the contact lens wants to position. So for this patient, we need the front toric. A thicker lens is not going to cut it. We have to verify that the lens we're using has a toric periphery, that it's rotationally stable, and we can add the front toric optics to this lens. Now, while we're on the topic of pupil and understanding the action within the pupil, one of the things you might consider is doing topography on your presbyopes with lights on and lights off, just to have some appreciation of scotopic versus photopic pupil. That will give you some idea if you were having to worry about the distribution of the powers within the lens that you're using. You know, as an example, if I'm using single vision optics, will my lens have a large enough optic zone in a scotopic condition? Is my multifocal lens going to provide multifocality in a more photopic situation when the pupil is smaller? So understanding lights on, lights off may be helpful with your corneal topographer. Now let's take a case, and here's a patient with a pretty high corneal astigmatism, 4.5 diopters of corneal cyl, so about 0.9 millimeters of corneal astigmatism. Our topography is saying the eye is limbus to limbus astigmatism, so that's telling me that the central cornea is astigmatic, but the peripheral cornea is astigmatic as well. The combination of high central corneal cyl and peripheral corneal cyl together tells me that it's almost certain we need some type of toric landing rigid lens. Now, if we switch over to the tangential map, what does it tell us? And here we see where the most radical point of curvature changes. The tangential map is very sensitive to where the eye alters in or shifts in shape. So in the case of the tangential map, it's saying there's a very radical change in curvature here. Now, is that due to the lid? Is that the lid force that's typically across the superior cornea, and that's creating a bit of a ridge where that lid pressure is causing the eye to curve? So something to consider. Now, when you look at these two topographies of the same eye, this is the axial interpretation. Here's the tangential interpretation. And what is the highest point on these cornea, on this cornea, either on the axial map or the tangential map? And a lot of practitioners will say that the highest point is the reddest point. It's the steepest point. And that would seem to make sense. It would seem intuitive. Now, would we say then, if we're looking at the axial map, that this is the highest point on the eye? It's the most curved. It's the reddest. So it must be the highest point on the eye. But then how is it possible on the tangential map that isn't the highest point, that suddenly this is the reddest or most curved point? It is really important, if none of this makes sense, that you consider that an axial map is the way you understand vision. It's the way you understand power. Tangential is the way you understand shape, how the eye alters in shape very radically, where it does. So neither tells you the elevation of the eye. And that's where the elevation map comes in. So you don't want to use axial or tangential and rely on them to give you perspective on the peak of the eye. And this is especially true in keratoconic patients when you're not sure, am I dealing with a volcano or am I dealing with the edge of the cliff? Am I dealing with the edge of a valley, let's say, and I'm at the top of the ridge about to fall into the gorge? So these maps are about different things. Axial is power, tangential is shape. Elevation tells you where the eye is highest and lowest. So in relationship to a best fit sphere, and I'll try to make sense of what that is, the best fit sphere tells you whether the eye is above that reference surface or below. So as an example, where you see red, that's where the tissue is very high in relationship to a sphere. Where you see blue, that's where the eye is very low in relationship to that best fit sphere. Now, if that doesn't make any sense, my colleague Patrick Caroline had to draw it out like I was a 2-year-old, because I'm a bit slow at most things. And this is one where it does take a while to get your head around this. We're so accustomed to thinking about topographies as red is steep, it's curved, it must be elevated. Blue is flat, it's not curved, it must be low, but not necessarily true. So yellow here is your best fit sphere, your reference surface. It is dropped toward the corneal topography. It's placed close in apposition in the center, generally at 0 elevation above the eye surface. So that's what we see here when we superimpose this on an OCT. Now where we would see red, that's where the tissue is above the reference surface. And that's what you're looking at here and here. The tissue elevation is high in relationship to the reference surface. Now that makes sense, doesn't it? Because we know that a rigid contact lens will virtually always bear hardest and bear first across the flat meridian of the eye, the meridian of least sagittal depth. So whenever we look at an axial topography, we can say, the flat meridian, that's where the lens should bear the heaviest. But the elevation map really tells us the definitive story. Yes, the flat meridian is where the eye elevation is the highest. So switching over to this blue, why do we see the blue at 12 and 6 o'clock? And that's, of course, because the tissue is behind the best fit sphere, or what we might describe as below the best fit sphere. So that's where you're going to have pooling. That's where the elevation of the eye is dropping or going away from the peak or going toward the back of the eye, and we are going to end up with fluid between lens and cornea because of that change in elevation. So if we were to switch over to the contact lens software, that will probably help to make more sense of this. So let's focus in on the flat meridian, the blue line that you see here. And you'll notice when we take this 4.5 diopter corneal astigmat, that 0.9 millimeters of corneal astigmatism, a very high astigmat, we show the landing at 9 o'clock, the landing at 3 o'clock, and that's because this is the meridian of least sagittal depth. This is the most elevated meridian. And that's where our contact lens is going to want to touch down. When we switch over to the steep meridian and look at that vertical, the red line, then we notice that where the elevation of the eye is changing so radically, we're going to get all of this fluid. So it makes sense, doesn't it, that the flat meridian would have all the bearing and the steep meridian would have all of the vaulting. So of course, when we put that lens on eye, a spherical lens on a really high toric patient, a very high astigmatism, we have a lens that really lacks the kind of relationship across the steep axis that we want. What's really good about this contact lens is notice the horizontal. The lens seems to sit on the rails at 9 o'clock and over at 3 o'clock. But the problem, of course, is across the vertical meridian, we completely lack the depth that's there, where we have no relationship across the vertical. We have good relationship on the horizontal, bad on the vertical. So this is a patient that clearly requires a toric lens. Now, when we look at a spherical cornea like this, and we think about elevation, we think about the peak of the eye across the flat and the steep, we think about the height of the eye as we go around the clock. What can we learn about this cornea beyond the key readings? So let's forget about central corneal astigmatism. Let's forget about this 3 millimeter circle that you see right here. Let's consider what's happening where the contact lens will land, and whether it's a corneal GP for single vision, a multifocal lens, or orthokeratology, it's out here that matters, because that's where our lens is going to touch down. So let's look at this point, this green-yellow border, principally around 8 to 9 millimeters out. And let's measure the sagittal depth. So, of course, what we're doing is we're defining a chord diameter of measure, and from that plane, we're measuring to the peak of the cornea. What is the height or sagittal depth of this eye? And Medmont is one of the few topographers that gives us sagittal depth, and we use that very frequently in almost everything we do in rigid contact lenses. So let's take that spherical cornea. Let's measure the flat. Let's measure the steep. What is the difference between the two? And there's an 8 micron differential between the height of the flat and the height of the steep. So if we place a corneal GP or an ortho-K on that lens on that patient, we're very likely to center that lens quite easily, because we have even distribution of height all the way around. We have essentially a symmetric elevation around the peripheral cornea. It's not very tough to center a lens on that patient. Now let's take this patient. We have 1.43 diopters of corneal astigmatism. So that's in the neighborhood of 0.28 millimeters of corneal sill. Not a very high corneal astigmat, but let's measure the sagittal differential. Height of the flat, height of the steep, what's the difference? And now we're at 33 microns, comparing those two meridians. Let's look at the lens on eye. Now, because this is a low corneal astigmatism, because it's a low sagittal differential between the flat and the steep, we have a pretty good fitting lens. We have a lens that lands at 3 and 9 o'clock. The relationship across the flat is really good. Across the vertical, we have a little bit of a channel, 33 microns at 12 and 6 o'clock, for that lens to freely move across that steep axis of the eye, and will be promoted. Good tear exchange will be promoted by the lid force and the gravity that's up and down. So this is ideal. Now, what about this patient? Now we have 2.5 diopters of corneal astigmatism centrally, but peripherally, where the lens would land down, we have both astigmatism centrally, but we have this limbus to limbus shape out here. So what does that mean for depth? If the center is highly astigmatic and the periphery of the topography is showing astigmatism. Well, let's measure the sagittal differential. Let's measure flat, measure steep. What's the difference? This eye has 115 microns of sagittal differential. So when we place this contact lens on eye, similar to our other high corneal astigmat, we can create a good relationship across the flat meridian, but the steep meridian, the vertical, requires a completely different depth. We need a toric alignment of this contact lens. Whether it's a Bi-Toric lens, if it's a single vision or multifocal GP, or if it's an Orthok K, it needs to be a peripheral toric design. But whatever we do, we need to create more depth along the steep axis. We need essentially two different lenses. We want one depth to match the height this way and a completely different depth to match the height vertically. So the elevation map gives us that understanding because we can look at the microns of height across the flat, the microns of height across the steep, understand the difference between them, and that gives us a perspective on how toric an eye we're looking at. So do we use the elevation map a great deal? And the truth is no. Really, it's kind of an academic analysis. It's helpful to understand, and we use it from time to time, but really Medmont's created this little attribute that measures sagittal differential, and it makes it about as efficient as it can be to understand when do we need toric and when do we need a symmetric rigid lens, and we'll review that in just a second. So for a patient like this, where you have 115 microns of differential between the flat and the steep, let's create a lens with about 115 microns of toricity toward the periphery, and then we get a lens that has a good relationship across the flat and a good relationship across the steep. Okay, now what about the keratoconic patient? What do we do with sagittal differential for this eye? Well, there's really no difference. We still want to understand sagittal depth, and we might take the meridian of least action or the most symmetric meridian. We're 1,500 microns here. If we go across the steep, we're 82 microns deeper when you average the elevation here and the elevation over here. Of course, asymmetric. And then we get another height differential here, another height differential here. The problem with the keratoconic patient is not that it's steep, it's not that it's a droopy apex, it's that it's such an asymmetric surface. That's what makes this eye so challenging for us to fit. Now, if we pull up the elevation map on this eye, it becomes very useful. What we'll do is we'll look for the highest point in the plus range, so the hot range of curvature or hot range of elevation, 112 microns. Find the opposing point along the same meridian, and we see minus 146 microns of negative elevation. So the eye goes from positive 112 down to negative 146, or a shift of approximately 258 microns. Now, many of you may have seen me share this at the OSO meeting or the other major contact lens conference there. And what this research showed, and forgive me if this is a bit of a repeat, but it's really an important study. When you have an elevation difference of less than 350 microns, remember that this patient has an elevation differential of 258 microns. When you're below 350 microns, corneal GPs work with great success. About 88% of the time, we were able to fit a successful GP lens on an irregular cornea. When that elevation difference was greater than 350 microns, that's when we were more likely to need a scleral lens. That's the green bars you see here. And you notice how much higher the green bars are going up when we're in that over 350 micron range. So when the asymmetry is under 350, corneal GPs more likely to be successful. Over 350, scleral lenses more likely are going to be needed to manage the asymmetry that we're dealing with. So for this patient with 258 microns of sagittal differential, a KBA lens, lens designed in Australia, was actually a great fit for this patient. And that was because we weren't managing a severe amount of asymmetry. But as that goes up, we're going to need to consider dealing with larger diameter lens, maybe a scleral, piggyback, something other than possibly the GP on its own. So some of the things that we might consider related to this story of microns is when you have greater than 30 microns of sagittal differential, that's when you want to consider using a toric corneal GP lens. When you're fitting an orthokeratology lens on a patient, when you have greater than 30 microns of sagittal differential, that's when a toric was likely to be a better relationship in the periphery. And of course, it's much more important in Ortho K that we have an ideal landing all the way around, because we rely on that contact lens fitting in the closed eye environment with whatever lid force is at work. We need that lens to be well centered. Whereas in a corneal GP and in normal conventional wear with lid interaction, a superior central GP fit is probably going to be acceptable if the optic zone is big enough, but way more sensitive in Ortho K. So 30 microns or greater, I would use a toric landing lens. And we're seeing with many of the manufacturers, that appears to be their threshold when they begin to use toric landing. Now, something I should make sure I communicate is where is that 30 microns measured, and that's at an 8mm chord. So measure across your corneal topography, 8 millimeters, take the flat reading, take the steep reading, and compare the difference between them. Now, related to the corneal GP versus scleral use, that number is 350. So greater than 350 microns, you're thinking scleral as maybe the lens of first choice. Less than 350, you're thinking corneal GP. Now, could we use the Medmont to fit scleral lenses? And today there's a few more instruments available on the market that have been designed very specifically for scleral application. And really, is our Medmont corneal topographer kind of obsolete in the scleral environment? And the answer is a definite no. I would not be convinced that the Medmont is not beneficial in scleral lens application. And one of those areas that it's been proven by at least 3 studies to be useful in scleral lenses is related to understanding the angle of the peripheral cornea. OCTs told us very early in the millennium that the eye begins to form this angular shape. So when you reach around 10 millimeters across the cornea, through the peripheral cornea and limbus and onto the sclera, the surface is best described as a tangent or an angular surface. Now, this is not true at the nasal junction of the eye or the nasal portion. There normally is a slight limbal junction on the nasal side, but around the rest of the sclera, it typically is more angular, like this is. So what does that mean? Well, if you could measure the angles that form through the peripheral cornea at around 10 millimeters, maybe to 11 or more, then you can begin to predict the angle of the surface all the way across to around 20 millimeters. So that's a healthy way into the sclera, well past the diameter of most of our sclerals if they're typically 16 to 17 millimeters in diameter. So what are we saying? What can we do with the Medmont? Well, if the Medmont can measure sagittal depth, and it's always been able to measure the height of the cornea across a 10 millimeter chord typically, and we can measure the angle that forms at around 10 millimeters. If we can get a few data points past that 10 millimeter chord, and the Medmont typically gives us a 10 to 11 millimeter single topography and full visible iris diameter in a composite map, well, then we should have lots of these peripheral points to estimate the depth, the sag of our scleral lenses. So the Medmont composite eye capture becomes a very critical tool to use in combination with your scleral lenses. And as all of you know, using the composite, what it does is gives us a different fixation point so that we can push the rings far out to the periphery of the cornea. We're not only getting data centrally, but we're getting these data points to stretch all the way out to the temporal side, superior, nasal, inferior. All of those are converted into a corneal topography. They're merged together to create a larger view of the eye. So here we see our Medmont single map, which gives us 10.3 millimeters diameter on this keratoconic eye. Pretty good. Certainly a large diameter of information, and possibly enough to predict and estimate the height of scleral lens we need. But of course, using the composite would make far more sense. The Hall study, Lee Hall in the UK, looked at Medmont's ability to estimate the limbal shape accurately, and he felt that in his modeling that Medmont did a very good job with the composite map at being able to determine the peripheral cornea and limbal shape. So if we can get those data points out there in the periphery, then we can possibly estimate the height of lens that we need for our scleral fits. So within your attribute window, and Jason and the team in New Zealand can assist with finding this attribute if you need it. It is known as the Chord attribute, or estimated height attribute. And what it'll do is it will give you an understanding, an estimate of the height across 0, 180, 150 degrees, 330, and 30 to 10. Now, why these three? Well, generally we have really good topography across the horizontal meridian. Lid and lashes never or rarely an issue. So understanding the depth or estimating the depth across the horizontal, pretty easy. We can usually get out to 150, 330. We can usually get out to 30 to 10. Going vertical can often be a challenge with some of these deep set eyes or patients that just struggle with getting their fissure open enough. So we've concentrated the attribute on the areas where we're most likely to get good information. So let's just focus on that section. We're going to click on Chord. What you're going to do is enter the chord diameter of measure. So in your area of the world, the CAT lens, or known internationally as the ICD Scleral Lens, it's a 16.5 diameter lens that lands at 15 millimeters. Its sagittal depth is calculated to a chord diameter of 15. So you would key in that 15 millimeter chord here, and it will estimate the height for those various meridians. So then we simply take a very simple formula. What does the Chord attribute suggest? The flat meridian is about 3,707 microns. If I add in my fluid layer that I want on application, that tells me the starting sagittal depth of lens that we need. So the tool can be used, although it's a corneal topographer, it can be used very accurately with your scleral lenses in predicting the very first lens. Now, what it does require, of course, is our ability to image the vast majority of the cornea. So if you've got a corneal transplant patient and the rings are just completely distorting toward the periphery, then that's going to limit your ability to accurately estimate the height of that anterior chamber. But for most eyes that we're able to reflect the rings to the peripheral cornea, we should get a pretty accurate interpretation. At least that's what the studies have borne out. Now, we didn't talk at all about the Medmont contact lens software today, and that's a really important component related to corneal topography and the fitting of contact lenses. Jason wanted to talk about some of the other areas that we might use the Medmont for that we could consider related to any of our contact lens fits. So if you feel like you wanted to learn a little bit more about the contact lens software, then make sure you go to the Medmont training videos. There's various tools that have been created for the regular cornea, the toric cornea, the irregular eye, the Orthok, and so on and so forth. So I hope this session has been valuable to you and that you've been able to pick up a few things that we could use. If you have any questions, please use the remaining time and don't be afraid to just key into that little image board any of the questions that come to mind, and Jason and I will endeavor to get back to you on them. And Jason, did you have any words that you wanted to finish up with?
No, thanks, Randy, for your time in presenting that. Very useful information there. I'm sure everyone would agree. As Randy alluded to, if anyone does have questions on the presentation today, you can email me directly, jason@medmont.com. Alternatively, head to our YouTube channel, type in Medmont International, and you'll see this recording there in a couple of days. As most of you may have attended the previous one, you'll know that we'll send you out a copy of the recording as well. So again, feel free to contact me directly, head to our website or the YouTube channel and seek further information. Thanks again for your attendance, and as always, Randy, thanks for a great insight.